12 o'clock. I know we'll have others join us as people kind of finish with their morning and get ready for our excellent webinar today. But I wanted to hand things off to Evelyn and let her introduce Richelle and talk about the Heartland Health Resource Center as we begin our day.
Thanks, Robert. It's great to see so many folks joining us today. I know we have a few folks joining us from our last informative session, and then it's nice to see some new faces too. I'm Evelyn Nelson from the Heartland Health Resource Center. We're really happy you're joining our Resource Center education series focused on telehealth billing, coding, and policy. Just a few notes. The session's being recorded, and just letting you know, we'll share it with you afterwards. Your microphones have been muted, but please unmute or use the chat to talk. And you can test out the chat by typing your name and organization. That'll help us know that the folks who are on the call today. We appreciate you keeping your camera on. It kind of helps us feel like a connected group. So if you're able to do that, we appreciate it. It's a-okay if you're also eating your lunch, or I know it's a busy time of year, so we just appreciate that you've been able to join. Of course, if you're not able to turn your camera on, we also understand that. Your completion certificates will be emailed. So it's important to sign on with your first and last name so that we can identify you and make sure we get your certificate to you. You can do that, you can rename by using the 3 dots on the Zoom screen, and then you'll be able to type in your full name. So let's get started. I know Dr. Marting has some fantastic information, so I want to make sure we have plenty of time for her information and your excellent questions. So Richelle is a local attorney who's also unique in being a registered health information administrator and a certified medical coder. Her practices focuses on medical billing and coding, and then also reimbursement. She has expertise in HIPAA privacy and security, in health information management, and in regulatory compliance. She's worked in-house with healthcare organizations ranging from assisted living, physician practices, ambulatory surgery, hospital, and health systems, as well as serving as an interim health system privacy officer. So again, we really appreciate the wealth of expertise, and with no further ado, please take it away, Richelle.
All right, thank you, Evelyn. So this afternoon's topic on completing the CMS 1500 claim form, oddly enough, is something that's kind of exciting for me because it kind of goes along with coding and billing in that it's extremely hyper technical. And what I'm going to do this afternoon is kind of orient you to some of the key resources on how to complete the CMS 1500 claim form, avoid some common errors that I see that can cause claims to be rejected when you submit them to your clearinghouse, or denied if they make it through the clearinghouse and get to the insurance company, and kind of help you with some of the technical pieces of filling this claim form out with a focus on how they apply to telehealth services. Now, one of the things I've got on this first slide, and I will also, Evelyn, send out the slides so everybody can have a copy of that along with the recording too. When you get the slides, I've got some hyperlinks here to some materials that are really helpful resources. This first one is just an electronic copy of the CMS 1500 claim form. And if you want this afternoon, it may be helpful to, I've got some screenshots of the claim form and what it would look like if you were to print this out and look at each field individually. It may be helpful for you too to go out on the internet and just find a picture of the 1500 claim form so you can kind of look at it and walk through the fields with me. And then the second link is the Medicare Claims Processing Manual that walks through every single field on the claim form in detail, and Medicare's very specific requirements for what goes in each field and how the information is to be completed. So this one-page claim form with 33 different fields on it, has a several 100-page manual on how to complete it. And I think it's just fascinating. It's fascinating to me. We may talk later in the year about a form called an advanced beneficiary notice form. And it's another, what looks like a fairly simple, straightforward one-page form with hundreds of pages of instructions on how to complete it properly. So it's just fascinating to me how detailed some of these instructions get. And I think it's just very eye-opening when you look at that manual to see how easy it is to have an error on a claim that prevents you from getting paid. And sometimes it may have nothing to do with the service itself. It's just some of these really detailed, hyper-technical requirements that Medicare has for the claim form. And this afternoon, I'm going to be focused on the CMS 1500 claim form. So this is the form that's used for professional services. If you are billing for healthcare practitioners and the professional component of their service in a facility-based setting, like a hospital-based setting, an outpatient department, a provider-based clinic that's actually kind of treated more like a hospital outpatient department than a professional freestanding office or other clinic setting, then we may be talking about a different claim form, the UB04 or the CMS 1450 claim form. But don't worry, we'll have a session on that too. And some of you may have a combination of both. So both of those sessions may be helpful. But this one's going to focus on the CMS 15 claim form in particular. And just to give you an idea of some of the hyper-technical requirements that can cause issues on your claims and how they are processed successfully or unsuccessfully, take a look at some of these really detailed requirements on the CMS 1500 claim form. You may not consider these fun facts, but I think they're interesting facts. We've got a number of date fields on the CMS 1500 claim form. So this might be the patient's date of birth. This might be a date of injury, or if we're talking about an accident that has occurred or a work-related injury. We've got date of service. And in those fields where a date is collected, we have different formats, right, that could be entered. We could have an 8-digit month, day, year, or we could have a 6-digit month, day, year type format. No punctuation, so no dashes or no slashes in between month, day, year. But you can actually have denials if you don't have the date formatting correctly. And so looking at these fields on like a date of service, if you can do those either in 6 or 8-digit format, but whatever you choose has to be the same across all of these fields. If you use 6-digit in one and 8-digit in another, your claim can be denied. So it's just kind of an interesting, insight to me on how detailed some of these requirements get. So we're going to take a look at that. And what I'm going to do, I've kind of dissected the CMS 1500 claim form into sections. And we're not going to cover every single field on the 1500 claim form this afternoon because of the several hundred pages of instructions. We could have a whole day seminar on going through some of these fields. But what I do want to do is pick up out a few of the areas that have some really specific requirements where I commonly see errors and sources for the reason claims may get denied. And one of the things I want you to keep in mind too, when we're talking about some of these hyper-technical requirements, these aren't necessarily requirements that you or your coding and billing staff need to have memorized, but being aware of what those requirements are for Medicare or other payers that might be different than what we see on these slides allows you to create some logic in your billing software to know these things for you. So for example, you might have some logic built into your software that looks at field 3, which is a patient date of birth field. And if you don't have 8 digits, if you have less than 8 or more than 8, or the length of that field is not equal to 8 characters, then an edit or an alert or an error pops up, and that claim never even goes out the door. It never even leaves your system until that issue is fixed. And so what that helps you do, building that kind of logic into your system, is make sure that your claim goes out clean the first time it goes out the door. It helps make sure you'll get paid, but it helps you get paid faster. If we have these kind of hyper technical errors, we've got dashes or slashes, or we've used an 8-digit date format where we needed to have 6 or vice versa, that's just delaying the time frame that it takes for you to get paid, and it's increasing your time and expenses and resources to get paid for that service. That we want you to be able to just send that claim and get payment automatically without incurring that additional time and labor to get these services paid. And unfortunately, what I see a lot of times with some of those kind of technical errors on, something as simple as the format of a date, is when they're denied, providers don't work them or correct them or resubmit them, and they're written off, and you never get paid for something that could have been a really simple claim processing issue. So what I've got here is kind of the top third portion of the CMS 1500 claim form, and we're going to take a look at some of these fields in more detail. The first of those is this field number 3, where we've got the patient's date of birth. This is the first date field where we've got a requirement. If we go back one here, right? Field 3, the patient's date of birth, that it has to be in an 8-digit format. Whoops, I'm sorry. Got click happy with my scroll bar there. Now take a look at the claim form itself though. Medicare requires that you have 8 digits in this field, but the claim form itself says month, day, year. When I count, that's 6 digits, but that is not consistent with Medicare's requirement that this be in an 8-digit format. So this is the first field where I see some common errors that we get, denials or rejection from a clearinghouse or a denial from an insurance company. That should be pretty easy to prevent. And I think the source of that confusion is the claim form itself is written in a 6-digit format when we actually need 8 in that field. Down at 11A is the next place where we see the insured or the patient's date of birth with the same kind of issue. It's written on the claim form in a 6-digit format, but Medicare requires this be in an 8-digit format. So we have the 4 years for the year, not just 2 digits. And because what we're looking at is a copy of the claim form, if you were to print the claim form out and submit it in hard copy, this is what it would look like. But you don't see these fields necessarily when you're completing an electronic claim. When you are completing a hard copy claim, though, these are particular sources of confusion because of the way the claim form has these fields labeled. Now, I want to look at the signature field down here too. So this signature field is for the patient's signature. And of course, because we now submit the vast majority of our claims electronically, we don't actually have patients sign the electronic claim, right? And we don't even have patients sign a hard copy claim form. What we do during our registration process is have the patient fill out some paperwork where they agree to allow us to submit claims to their insurance companies on their behalf, right? So number one, it's important that you do actually have that underlying registration paperwork with the patient's signature agreeing to allow you to submit a claim on their behalf. Because what we're doing on an electronic basis is saying something like signature on file in this, move forward here, in this signed field. And that's okay. Medicare allows us to have signature on file. But I think it's very important to make sure our registration paperwork is collecting the patient's signature with this statement or something very similar to it. I authorize the release of any medical or other information necessary to process this claim. I also request payment of government benefits either to myself or to the party who accepts assignment below. And we're going to talk about accepting assignment in just a little bit. And the reason I'm emphasizing this is because I think a lot of our billing systems automatically, for every single electronic claim, would enter signature on file in field 12 automatically. There's nothing manually we're doing on a claim by claim basis to confirm, yes, we do have a signature, or no, we don't. And it's very important that you do have that signature in your paperwork. Otherwise, what we're doing when we send a claim electronically and by putting that signature on file statement by default could be misrepresenting the signature that we do or do not have on file for the patient. And we want to make sure if we're telling Medicare, if we're telling Medicaid or Blue Cross that we have the patient's signature with those particular statements, that we are in fact collecting that signature in our registration paperwork. That
So,
doesn't mean,
electronic
oh, I'm sorry, go ahead, Robert.
I didn't mean to interrupt, but I just wondered about electronic signatures, as many people are going to online paperwork.
Yes, and that's perfectly fine. So a signature, that's a great question in this section 12. That doesn't mean we need a wet signature on registration paperwork like we often got. An electronic signature is fine. That's a great question too, that we could probably spend a half-hour session on. What is a valid signature that could allow us to say signature on file here, or further down when the provider's signing a document. So of course the patient's wet signature is fine. If a patient is physically unable to sign paperwork, whether that's a wet signature or an electronic signature, this could also be the signature of a legal representative. So for those of us that are seeing patients who are under 18, this is kind of a contract. Signing this paperwork saying, doctor, you can bill for services on my behalf. It's a quasi agreement between patient and provider, something that minors who are not allowed to consent to services or contract for services on their own technically can't do. So if this is mom's signature or dad's signature or guardian or other personal representative, durable power of attorney, that's okay too. It doesn't necessarily need to be the patient in those situations where someone else is consenting or contracting for the services that are being provided. And the electronic signature, so Robert, that can be electronically completing our claim form. It could be the patient typing out their name and consenting to services. I like, if you've ever seen the way DocuSign or HelloSign or those types of electronic signatures are created, or signatures even in your medical record system where it stamps it. It says Richelle Marting, April 30th at 12:18 p.m. I like that type of electronic signature. That's really the best way to get an electronic signature as opposed to free texting, because a free text, that could be me signing my husband's name, and there's not a lot of assurance or kind of an affirmative representation that the person signing that document is who they say they are, to kind of give the legal enforcement that a true electronic signature has. So that's a great question. And the same for in box 13, the insured or other authorized person's signature. I authorize payment of the benefits to the undersigned physician or supplier. So again, if we say signature on file, which we're probably doing if we have an electronic claim, we want to make sure we have a statement in the registration paperwork, whether that's hard copy, wet signature, or Robert, some kind of electronic registration paperwork that they're doing prior to this service, saying, I agree for the payment to go to my provider directly as opposed to coming to me. And the source for getting the patient, the reason we're getting the patient's signature in our registration paperwork that allows us to represent on the claim form that we have that signature on file, and that allows us to collect that payment on the patient's behalf, is because really under the patient's insurance policy with, let's say, Blue Cross and Blue Shield, it's the insured's benefit to get paid for the benefits under that insurance policy. If I have an office visit that's part of my insurance benefits, that's really my individual benefit that Blue Cross pays to me. But the course and the practice in healthcare, of course, is for me to assign that benefit to my healthcare provider. And they take care of the billing for me. And in exchange for taking care of the billing for me, they get that payment directly from Blue Cross instead of Blue Cross issuing a check to me that I then hand over to my healthcare provider. So that's kind of the legal background and basis for when and why and how we're getting those signatures on file and why we're making those representations. So this is kind of the second piece of the claim form. And this is where we're entering some information about the patient's conditions and the reasons for services. And here in field 14, this is another date field. We see several different date fields here. And in this section of the claim form, we can have either 6 or 8-digit dates, essentially meaning we can have 2-digit years or 4-digit years. It doesn't matter from Medicare's perspective, so long it's the same across all of the fields in this section. If I were to put 6 digits here in field 14 and 8 digits here in field 16, my claim might get denied. And that's kind of a silly reason to have it be denied. And again, I don't think this is something that you and your staff have to memorize. Build the logic into your claim, your billing system to make sure that we're doing it the same across the board. That logic may also need to be customized by payer, because while these are Medicare rules, Blue Cross or Aetna Humana may prefer a 6-digit format in all instances. And so we want to make sure we're following those requirements with each payer's expectations. Now, I want to talk in particular about field 17. And field 17 is talking about the name of the referring or the ordering or the supervising provider for a particular service. We have a couple different items within this field 17 that we have to complete. And the first that we're going to see over here on the left, we're going to look at a 2-digit qualifier that needs to go in this little box. And then we're going to have the provider's name, the ordering, referring, or supervising provider's name. And then in box 17A and B, we're going to have more details like the NPI number of that ordering, referring, or supervising provider. Now, I'm going to zoom in on that field in particular, because we've got some specific instructions that can vary depending on the services that we are billing for and how we designate the referring, ordering, or supervising provider in this field 17. So referring and ordering provider, I think of any service that requires a referral or an order. That's what we're going to put in this field. Who is sending the patient to us? And one of the reasons for Medicare in particular that we have to put the name and the national provider identifier number of that referring provider here is that Medicare has rules on the credentials of the providers that can order certain services, right? So certain services like diagnostic tests may require a physician, an MD, a DO, a chiropractor, or podiatrist to order that service. Some services may require that the referring provider, whether it's a physician or a non-physician practitioner, participate in the Medicare program. And so that's important when we have the NPI here. It tells Medicare who that provider or practitioner is, so that Medicare system has some edits to look up that NPI number and see if that professional is enrolled in the Medicare program, has the types of credentials to order the types of services that we are billing for that we'll look at later on the claim form, and that they're eligible within the Medicare program to do that. So there's several different edits that are happening with this field. And I see a lot of denials for services when this field has not been completed correctly. If we have services that involve different ordering, referring, or supervising providers, we actually have to separate those out on separate claim forms, because each claim form only gives us the opportunity to identify one ordering, supervising, or referring provider in this field. Now, if we've got multiple, we break those out on separate claims, even if we're talking about the same patient, the same data service, the same encounter. We may have to break that out onto separate claims. Generally, this is going to be a physician, but it doesn't necessarily have to be. It could be, for example, a physician assistant or a nurse practitioner who's ordering, referring, or supervising services that we may identify in this field. So then I want to look at this box over on the left where we put qualifiers. These are 2-digit They almost look like modifiers, if you're familiar with modifiers that are attached to HCPCS and CPT codes that go in this field. And so when we enter the name of a provider here in this kind of long space, the 2-digit qualifier over on the left identifies more specifically, are we identifying a referring provider? Are we identifying an ordering provider? Are we identifying a supervising provider? Again, the reason that that's really important is because some services require a supervising provider. Some services require an ordering provider. So if we put the indicator DK here for an ordering provider, and the services that we're identifying by HCPCS or CPT codes, one, require an ordering provider, our claim is going to be denied if that's missing, if DK is missing. And if that particular service is required to be ordered by a certain type of professional, like a physician, then if our NPI number is not associated with the appropriate credentials, we may also get denied for that service. So then Medicare defines what does it mean to be a referring provider? What does it mean to be an ordering provider? What does it mean to be a supervising provider? That tells us which of those qualifiers we need to have over on the left associated with the provider's name and NPI number on the claim. So the referring provider it's exactly what it sounds like. That could be a primary care provider referring a patient to a specialist. Okay. The ordering provider, this to me is a little bit, it blurs a little bit with the concept of referring, but ordering, I think of something more formal. It's the provider that puts in an order for a service or a test. It's not simply saying, Richelle, go see this mental health provider. Richelle, go see this orthopedic specialist or neurologist or whatever the case may be. This is a physician putting in an order for a diagnostic test, putting in an order to have an item or service or DME supply or something along those lines. So it's in particular for items or services that require an order or a prescription. Diagnostic tests, lab, pharmaceuticals, etc. So some examples for Medicare in particular, and again, this is going to vary payer by payer. They may have different or additional requirements on when orders are provided or are required, when we may need to have a DK indicator with the name of a professional who's ordered services. Are covered services that result from an order. It's pretty straightforward, but some of those services in particular are hepatitis B test or vaccines, diagnostic lab, radiology, x-ray, consult services. So this would indicate who is ordering the consult when the consult's required, durable medical equipment. When the ordering provider is the same as the performing provider, so in your office setting, Dr. Marting orders a diagnostic image and the x-ray is taken in the office and billed under that same provider's name, that's fine. But we may still have to have the ordering provider identified with DK and a name and an NPI number here in field 17 in order for that test to get paid. Same for in-office clinical lab tests that are being done. The other element of this is the supervising provider. So if you've heard of the concept, Medicare's concept of incident to billing, it is a billing mechanism that allows us to take the services that are provided by non-physicians and bill it under the name and number of the supervising physician. And the idea is that the patient has seen the physician who has developed a plan of care, and other folks in the provider's office or in the provider's team are carrying out that plan of care. So that may be coming to the office for blood pressure checks, or in our case, maybe a telehealth visit to talk about blood pressure management and medication and symptoms that the patient's having. So this may be a nurse, it may be a nurse practitioner, it may be a physician assistant, where the service that's being provided, there is no actual physician involvement in that particular service. But because it's incident to a physician's previous service and plan of care, we may be able to provide it and bill it under the physician's name. And when that's done by someone like a nurse practitioner or a physician assistant who can separately bill for services under their own name or number, but when they do that, they get paid a little bit less. For Medicare, they get paid 85% of the fee schedule amount as opposed to 100% when it's done by a physician. And if we meet all of those incident to billing requirements for Medicare to report it under the physician's name, one of those requirements when the incident to service is provided is that it has to be provided under supervision of a physician. So when that's done, we have to identify the supervising physician in this field 17. So let me go back just a couple of slides here. And we have to put the qualifier DQ here in field 17 over on the left to say, here's the name of the physician supervising this service that's been provided by someone else. We'll talk about that someone else in just a minute. And the NPI number. And Medicare has some rules on the name and the NPI number that goes in field 17 for who is supervising a particular service. So when we're doing incident to, the provider who performed that initial service to say, here's the plan of care that other folks on my team are going to carry out. That is the name and the NPI number that we're going to put in field 17. On a particular date, when those services are carried out, that initial physician may not be in the office, may be on vacation, may not be available. So we're going to identify who's actually supervising on a particular date somewhere else. But here in field 17, it's the provider whose plan of care is being carried out that we are identifying as the supervising provider in field 17. If we're talking about physician extender, a non-physician practitioner like a nurse practitioner or a physician assistant, if they are the ones referring a patient for service, we're going to enter the name of their collaborating or supervising physician in field 17. Okay, so nurse practitioner collaborates with Dr. Smith. They have a collaborative practice agreement under state law. Then the name and the NPI number we put in field 17 is the collaborating provider. If we're talking about a physician assistant under a supervising physician agreement under state law, then we're going to put the supervising provider's name here in field 17. Okay. If the services involved are physical therapy, speech therapy, occupational therapy services, then we're going to put in field 17 the name of the practitioner who certified the PT, ST, OT plan of care. And we're going to add the referring, ordering, or supervising providers in specific NPI number to field 17B. That I think can be what a lot of practices will do in their billing system in field 17 is start to develop a dictionary of ordering, referring, and supervising providers. That's easy when the ordering, referring, or supervising providers in our practice, we already know their names, we already know their NPI numbers. But if patients are coming to us for services referred, ordered, or initiated by practitioners outside of our group, we have to get the NPI numbers of that individual professional to be able to put here in field 17B. And so we start to create kind of a data dictionary of providers that we can input here and what their NPI numbers are. They have to communicate those NPI numbers to us to have our claim forms completed correctly. All right, so we spent what, almost 10 minutes on field 17 on the claim form. And again, that's one in particular. These are Medicare rules. Blue Cross, Aetna, Humana may have payer-specific rules and even service-specific rules on what to put in 17, which of those qualifiers to put, whose NPI number to put in there that we have to be aware of. So one thing that then the next thing I'm going to look at, if the date that the care is assumed, or excuse me, box 19, this is additional information, which is kind of a catch-all, free-for-all field that we can add an explanation about other things that we're putting on the claim form. If, for example, we are billing for a service and we put a modifier 22, saying it was an increased or particularly complex service, we may add a brief explanation in field 19, like see enclosed progress note that explains why it was increased or prolonged or particularly complex. Some specific instructions that Medicare give us for this field is if we have a provider that assumes the patient's care within a global period, meaning they don't provide the entire global service, but only a portion of that, like a patient who's had a procedure that has like a 90-day or a 10-day post-operative period, then in this box 19, we put the date that our provider assumed the care within that kind of global period in box 19, and that communicates to the payer that this is a segmented global period and alerts the payer they may be getting two bills, one from a provider who does part of it and another provider who assumed care in that post-operative period or that global care period. And it also helps the payer calculate how we divide that amount between provider 1 and provider 2. That's important to have that detail because without it, Medicare or the payer is going to process the claim that they receive first and deny payment for any other providers in that global period, unless you've indicated, no, they only provided a portion, we provided a portion, and here's the date that we picked up the care. If we are billing for an unlisted procedure or service, which is kind of a catch-all HCPCS or CPT code for a service that is not classified more specifically, it's kind of like and everything else that doesn't have its own unique code. They usually end in a 9-9 in the CPT book. Then here in field 19, we would describe the particular service that we've provided that's reported with an unlisted procedure code, and that helps the payer find kind of the next closest CPT or HCPCS code to the service you've provided, and to calculate a payment amount based on something that's comparable to what you've done. So now I'm going to look at field 21. This is where we put our diagnosis codes. And of course, this has changed in the last 5 years or so when we moved to ICD-10 instead of ICD-9. And because there may be some payers who are still using the old ICD-9 code set, on the claim form, there's now an indicator to say whether you are reporting ICD-9 or ICD-10 codes. So we just put an indicator on what code set we're using on the claim, and it's a 0 for ICD-10 or a 9 for ICD-9. The reason you may still have some payers using ICD-9 codes is that the HIPAA mandated requirement to move to ICD-10 applies to most insurance companies, Medicare, commercial insurance, but there are still a bunch of payers that were not required to adopt ICD-10. That may be auto liability insurance, workers' compensation. While many of them did, there could be some unusual circumstances where you're still using old codes and putting a 9 here instead of a 10 and reporting ICD-9 codes instead of ICD-10 codes. So the other thing I want to point out here is we can report up to 12 diagnosis codes on each claim. And I encourage you to report all diagnosis codes that apply to the services that you are providing to a patient, not just the primary one or ones. And we could spend a whole session talking about when I teach coding, I have probably 10 weeks where we talk about diagnosis coding rules and how to report them and when to report them and what order to report them in on the claim form. Those sequencing rules that come from the ICD-10 official guidelines for coding and reporting could also create a really easy way for payers to deny claims when we put in diagnosis spot A, a condition that is maybe the primary condition we're treating during a visit, but according to the guidelines, that code cannot or should not be sequenced first because of different sequencing rules in the book, where some other code is always put before it. So particularly with what you're putting in box A, you have to be aware of the ICD-10 guidelines and the definition for a first listed diagnosis, the condition that's chiefly responsible for the services that you are providing, with an asterisk that there may be some specific sequencing rules involved. I was just looking at this for a clinic that does oncology services, and they were reporting in box A the code that describes the patient's malignancy, right? That makes sense because that's what we're treating with oncology services. However, they were getting a lot of denials from one particular health plan. They're like, what the heck's going on? It's a valid diagnosis code. It's the correct diagnosis code for this patient. And what we found when we were looking at the claims, there is a rule in the ICD-10 guidelines that says when a patient's coming in for radiation oncology, there is a Z51 diagnosis code that has to go first in this box A, followed by the code for the malignancy. And that one simple thing was causing a lot of denials in a situation where they didn't realize there was a coding issue at play. We also put the ICD-10 codes here without any punctuation. So if you're familiar with the format of ICD-10 codes, we typically have 3 digits, a period, and then up to 4 digits afterwards. It can be anywhere from 3 to 7 characters. The period is not reported on the claim form. So it's just 3 to 7 characters, no punctuation, that go in this field. Okay, so then box 23, this is where we collect the prior authorization or pre-certification numbers. So any services that you're providing that require prior auth or require pre-certification are going to be denied if you don't get the authorization and include that number in this box on the claim form. If we have a hospice or home health agency and we're providing care plan oversight, that's an evaluation and management type service. And so it's kind of a weird quirk in Medicare billing rules. It's not really a prior authorization number, but when you are billing for the care plan oversight for your providers for a home health episode of care or a hospice episode of care, we put the NPI number of the home health agency or hospice in this box in order for Medicare to pay for the provider's care plan oversight. If we are billing for in-office labs that are CLIA waived labs, we put our CLIA number, our CLIA certification number for our in-office CLIA waived lab here in box 23 as well. And that's what lets us get paid for labs when we are not a Medicare enrolled laboratory service provider. So now we're getting kind of into the meat of what we're actually doing for the patient on a particular data service and how we report that. And so we've got, this is just one out of multiple lines, because if we're providing multiple services, we're obviously going to be reporting multiple line items on the claim form for those services. So when I say box 24, that's actually referring to all of this information, A through J, about a particular service. So we start with the dates of service, which again can be 6 or 8 digit. We just have to be consistent with how we're reporting that. And I want to talk about a few of these kind of subfields within the services that we're providing that I see a lot of errors on commonly. But first, before I get into those, each line item actually has 2 rows. And so what you see on the top, that red shaded portion, is where you can provide additional information about the services beyond just data service, place of service, code, modifier, and et cetera. So for anesthesia services, for example, you would put in this box, in this red shaded area, the anesthesia start time, the anesthesia end time, the total anesthesia time, the time units, the base units for the payer to process that. If we are providing, if we're doing injections for a patient, if you're in an in-person setting, then we put the NDC number for the substance that we are injecting during administration procedure in those fields. And then we also put an indicator of the units. So UN, F2, there's all these different indicators on how we report units of service. Okay, so let me start with the data service, and that seems fairly straightforward for a lot of the things that we do. That we see a patient via telemedicine on April 30th. We put April 30th as the data service, right? But there are a lot of things that we do. We're going to talk about next week some kind of quasi-telemedicine services that may span a period of time. And so there's always a question in those services that may start and end on different dates, how we report those, what we designate as the data service. So Medicare has this general rule that expenses are generally considered incurred on the date that they are received by the patient, not when they're ordered, not when they're paid. Okay, that makes sense. Typically, the from and the to data service are going to be the same. If we see a patient on April 30th for a telemedicine visit, we're going to put April 30th, 21 in from. We're also going to put April 30th of 21 to, from and to April 30th, 2021. This gets more complicated for services that are broken into components, like imaging services, where the patient may come in for a test on one day that doesn't actually get interpreted until another day. But if we are billing for the global piece of that, which data service do we use? How do we report that? And so Medicare has some rules for those services that are broken into components like that. Typically, the date that you're going to identify, if you're reporting the global service, is the date that the test was actually run. So the date that the X-ray was taken, even if the interpretation's not done for another few days. When I send these slides out, I'd encourage you to pull up this link. It's a really excellent resource that Medicare has put out on deciding when you can even bill the global service, who bills for it, when you can't, because in a lot of provider arrangements, you have to be under a certain type of contractual arrangement for both providers to be able to report a service as global. You have to be within the same Medicare locality. So if one provider's in Kansas and you're interpreting providers in Missouri, those are different Medicare localities that you may not be able to bill globally, and you may have to separate out as professional and technical components. And in those cases, the rules are different on how you report the dates of service. The technical component gets billed when the X-ray is actually done. The professional component gets billed on the date that it's actually interpreted. So we go into a lot more detail in those types of services, depending on whether you can or cannot bill globally. So I talked about care plan oversight, right? On the last slide, we'll put the NPI number of the hospice or the home health agency if we have a physician who's overseeing the plan of care. That's not necessarily a face-to-face service, so I consider it kind of like a quasi-telehealth. It's done kind of behind the scenes that we may be billing for. And Medicare's rule is that we put the data service we report is when we've met the billing requirements for that service. So we've met all of the elements and we're actually submitting the claim. Or we could put it at the last day of the month, or whenever that particular service has a 30-minute monthly time frame requirement. Whenever we've met that time frame requirement, that's the date that we could use. One of the two. But we cannot report and bill for the service before we've met all of the elements of that code to be able to report it. If we're billing for a home health certification or a recertification, the date of service is the date that we actually complete and sign that document, which may be different than the date that parts of the home health certification or recertification are completed. So as you can see, we're getting into some very service specific rules on how to complete this. And these are Medicare rules. We may have different or additional rules for additional types of services with each of our health plans. Transitional care management is another what I consider kind of quasi telehealth service that occurs over a span of time. This is when a patient is discharged from a hospital or acute care setting, and we are providing some of the pieces of a transitional care service are not face-to-face. It's medication reconciliation after discharge. We do have a face-to-face or telehealth visit with a patient within 7 to 14 days of discharge. But there are other things we're doing to kind of make sure medications are being taken appropriately. We're following the discharge plan of care. The idea is helping reduce the likelihood of a readmission that we know is a very costly process. So it's worth it for Medicare to pay us $100 or so to help keep the patient from going back into the hospital. So when we do that, part of the transitional care management service, among other things, is at least one face-to-face visit with the patient within 7 or 14 days, depending on the complexity of the patient. And so the date of service when the CPT or HCFIX code is a transitional care management service is the date of the face-to-face visit. Even if some of the transitional care management services that are a part of that code are not done yet and are done after the face-to-face visit, Medicare has that is the date that we would report. I would encourage you, if you're doing that service, to maybe not bill it on the date of the face-to-face visit, to wait until you've met all of the elements of the code and the service before billing. But when you do bill, the date of service you use was the date that you had the telehealth or the face-to-face service with the patient. If we are doing home PT-INR monitoring for patients who are being anticoagulated, we've got some specific instructions there on when and how we report the date of service, because those are happening over periods of time. We're not done yet. We are still on box 24A on how to report a date of service, something we thought that was very simple going into the claim form. But these are just some rules that come from Medicare's manual. Psych testing and eval, there may be, this may be done over a period of days, looking at documents, collecting information, but this is the date the evaluation is actually completed for a patient or signed off on for the patient. If we are providing post-operative care only, so remember, with surgeries, we've got this global surgical package concept, which may continue the day before or the day of surgery. It could continue 10 to 90 days after the surgery. And if our provider is only doing the post-op care, one of the things we do is report the code for the surgery the patient had, even if our provider is not doing the surgery. And we use a modifier saying our provider is delivering the post-operative portion of that surgery. And so we're getting a portion of the payment for the global surgical package for whatever that surgery was. But then remember, up in box 19, we have to add the date that our provider assumed care to help calculate how much of the payment that they are going to get for the post-op service. So now place of service. This in particular has been one box that has seen a lot of change as we've moved to more and more telehealth services, because typically when we do telehealth, a true traditional telehealth, the way that service is defined by Medicare, we would report place of service 02 in this box B. And that's relatively new. Several years ago, we might use an office place of service or hospital place of service. And the way that we indicated that something was done via telehealth was a modifier 95 over here. And when we reported 95, we were certifying or representing to Medicare, we've met all of those really hyper-technical telehealth requirements. We have a rural area, patients in an eligible originating site, and so on and so forth. About, I want to say 4 years ago or so, Medicare changed that and said modifier 95 is no longer required, and instead report place of service 02 in box B. And what that did from a payment perspective was pay us for the facility rate for a telehealth service and not the non-facility rate. For example, if we are in an office setting and use place of service 11, we get paid more for that service than if we are providing it in a facility-based setting, like a hospital-based outpatient department. And the reason for that is in facility settings, you get two charges. You get the facility fee and the professional fee. And Medicare said, gosh, if we are paying a non-facility rate, we're actually paying more for telehealth services in some instances than we would provide in a non-facility setting. And the provider billing for the professional service for a telehealth visit is not always incurring the facility expense, like rooming the patient, the overhead, the payment for the physical location, right? Because the patient's not there. So that telehealth place of service code actually affected how much we got paid for a telehealth service. You could then be compensated for the facility overhead portion by reporting the originating site fee. Now that is all sort of in a tailspin right now during COVID, where Medicare says instead of reporting place of service 02, report the 2-digit place of service code that you would report if you were actually in the room face-to-face with the patient, and we will pay you that amount right now during the public health emergency. But when the public health emergency ends, and maybe even for some other payers still like Medicaid or commercial payers, you may need to be reporting place of service 02. So I anticipate that that's going to be a change when the public health emergency ends for Medicare in particular. Here are a couple, office place of service 11 is a really common one, but there are other specific place of service codes that you can look at. These are all publicly available. You can search for it to make sure you're getting the most specific place of service code. A couple of specific rules for place of service. We're still using place of service 02 in Kansas for Kansas Medicaid and Missouri Medicaid, as opposed to reporting the place of service that would be used if you were delivering that same service face-to-face with the patient. For the place of service for like diagnostic imaging or things that can be broken into a professional and a technical component, like taking the actual x-ray, that's the technical component for the test, and the overreader interpretation is the professional component. And so in reporting the place of service for those, for the professional component, you're typically going to report the 2-digit code that describes where the x-ray was actually taken, like an IDTF, an independent diagnostic testing facility, an office setting, or so on. Even if the provider is not there in the office, and that's not where the interpretation was being provided. That's true under Medicare rules right now, even in a situation where global billing is not allowed. So if you're dividing the professional and technical components separately. Where you may have some differences is down in box 32 that I'm going to look at in just a second. If we are billing for the originating site fee, we've got the place of service codes that we could use may be limited because only certain settings qualify as eligible originating sites where the patient is located. Outside of COVID, for example, the patient's home, with very, very limited exception, is not an eligible originating site. So if we were to report code 12, the patient's home, outside of the COVID setting, we're not going to get paid for that service because the place of service doesn't match, is not an eligible place of service for that particular code. So these originating sites are waived during the public health emergency, but whenever that emergency ends, we're going to be restricted on the originating site place of service that we can report in field B here. So I'm going to go over to field D, and these are the CPT or the HCPCS codes and any modifiers that kind of qualify or explain how we're providing that service. So for now, for Medicare, when I send the slides out, you can go to this link and pull up all of those codes that are currently eligible to be provided via telehealth for Medicare, including those that are temporarily allowed through the end of the calendar year when the public health emergency ends. So right now, that's at least through December 31st of 2021. One thing I'll mention with modifiers is that if we're Kansas, Missouri, and Oklahoma, I think all 3 states are under WPS Medicare. WPS Medicare has a page on their website of what they call pricing modifiers that you add to the HCPCS or CPT code that affect the payment amount that you get. And if you are reporting any of those pricing modifiers, it has to go in this first modifier field on the claim form, or your service could be denied. The diagnosis pointer picks one of those 12 diagnoses that we've reported in A through, I think it's K, above, that are relevant to the services, and says which one of those diagnoses is most relevant to this particular line item. And you may have 5 different line items describing different services that you've provided. One, you may point to diagnosis A. The next one, you may point to diagnosis B. They don't all have to be the same for the same claim form. For example, years ago, I was looking at denials that a practice was getting for an in-office, what was it? Lipid profile test that they were doing in their in-office lab. And what they had done on every line item, the office visit, the lab, et cetera, they'd pointed it all to the same diagnosis. So a patient came in for ear pain, and then on the line item for the lipid profile, we were pointing to a diagnosis of ear pain. And Medicare said ear pain is not a valid diagnosis for a lipid profile and was denying all of those. So we weren't pointing it to the correct condition that explained the medical necessity of that particular procedure or service. Something to be aware of if any of your services are limited to coverage for a particular diagnosis or condition. Now here in box 24J over on the right, this is where if we're providing a service incident to a professional service, so a plan of care that was initiated by a provider, but that physician who initiated the plan is not necessarily the one who is in the office suite immediately available to supervise a service on a particular date that it was delivered. We still identify the initiating provider in field 17, but here in line 24, this is where we identify who was actually there and available to supervise the service on that particular date. So we may need a different physician's name and number here in box 24. And I know we're just 3 minutes over time. I'm sorry, I'm running a little bit behind here. I'll try to cover this thoroughly but briefly here in the last couple of slides. So this is the bottom of the claim form, and in box 27, there's a yes or no on whether whether we are accepting assignment for the patient. Just like the patient's signature, if we are saying yes, which we often are, we are accepting assignment of the benefit of payment for these services. We have to have the patient's signature assigning their benefit and their right to payment over to us in order to be able to mark yes. No signature, no assignment. Down in box 31, we do the same thing that we would do for the patient's signature, except here, this is the physician's signature. And the signature on file is the signature of the provider in line 24, whose name and number and credentials are going on this claim form as being responsible that the services were provided the way they're described, and they are making all of the certifications that you would see on the back page of this form. Now, I would encourage you to take a look at that, because if we are misrepresenting anything on this form, the provider whose signature we are putting in this box 31 could individually and personally be responsible for misrepresenting those facts and those statements that we're putting on the claim form. And then in box 31, if we're doing this incident to a professional service, the ordering provider's name, if they're providing the supervision, would be the provider here. Otherwise, it's the provider in line 24 who supervised on a particular date of service. And then in box 32, this is telling us where the service was provided. So if we're talking about the professional component of a service, the place of service in line 24 is where the test was actually taken, like where the x-ray was actually taken. Lowever, if the professional doing the interpretation is at home when they're reading that study, then we have to have the location where the professional component is actually provided identified here in box 32. And if that is a place where they're customarily providing the service, then we have to register that location in our credentialing information with Medicare or with other payers as a site of service where we deliver care or where we interpret services, or we're not going to get paid if the address we put here is not an address on our enrollment information with a health plan. Okay, I apologize. I went a few minutes over time. I think we may have some items in the chat. You're welcome to stay and join, and I can try to answer some questions here. Also, if you have any questions that I wasn't able to answer in the hour, which you very well may, since we've got several hundred pages of instructions for this, please do feel free to reach out to the HTRC technical assistance email address. I'm happy to answer those and get you responses. This is actually really fun research for me to do and to get you those answers if you didn't get a chance to ask or have them answered today.
We so much appreciate, Richelle, you covering such a complicated topic, and just making it more transparent so it's so understandable. So thank you so much for all your expertise and willingness to continue to answer our questions.
Absolutely. I do see one question in the chat about box 32 and FQHCs, whether that applies to FQHCs. And that depends on the payer that if the FQHC is submitting a claim, if they allow you to use the CMS 1500 form instead of the UB04, because a lot of payers will require a UB04 for FQHCs. But if you are using the 1500, then yes, you still need to put the service location in box 32 for the FQHC.
I don't see any more questions at this point, but I hope folks are able to join for your next presentation, which is coming up Wednesday, May 5th. And I know you'll be addressing Medicaid and telehealth. So keep the questions coming. We welcome them. And we'll make sure you have the HTRC link. And then please do join us on the next Wednesday. And thanks so much. I know I learned a ton with your presentation, and appreciative of all the great tips.
Absolutely. I'll send the slides out to you. You're welcome to share with those that attended. And as always, let me know if there are any follow-up questions.